This podcast is brought to you by the good people at Living with Hemophilia, the online hemophilia community brought to you by Bayer. Living with Hemophilia is the destination of choice for a plethora of useful info, like medical and non-medical tips, helpful advice, information on programs for all ages and stages, leadership opportunities and initiatives, sewing patterns, and videos, the best videos. And because it's on the internet, it's easy to find. Simply type livingwithhemophilia.com into your search bar, and there you are. Thank you, Internet. Join Bayer's community of fellow hemophilia patients, caregivers, and advocates as we put the live in Living with Hemophilia. You can even like us on Facebook. That's even better because you can use emojis on our Facebook page and receive all our latest updates. So check out Living with Hemophilia. And before you wish happy birthday to that friend from 3rd grade or share a funny meme about cats and Mondays, head over to Facebook and like Bayer's Living with Hemophilia page. You'll be glad you did.
It's the start of the year, new insurance plans, everyone just feeling the dread of wondering what's around the corner in terms of getting access to care and all of those out-of-pocket costs. Today we're going to have a conversation about the newest insurance issue that is directly impacting bleeding disorder patients and other high-cost disease states across our country. Welcome to Ask the Expert. I'm your host, Amy Board, and I'm really excited for today's episode. This stuff is so important. It's so important that you guys actually let us know that it was that important. We heard your feedback. We've already looked at our survey results from the beginning of the year, and insurance topics were right at the top with what you guys wanted to hear about. And so we really wanted to give this attention. If you haven't filled out our survey, there's still time. So go to www.bloodstreampod.com/feedback and let us know what you'd like to hear about. What are some of the topics that you are thinking about, that you're losing sleep over? We really want to hear from you. While you're at it, make sure to subscribe to our network of podcasts. Of course, Bloodstream with Patrick and Natalie, always a good time. And little plug, there's a new Bloodline series that's going to be dropping soon. I'm super psyched for that one. So make sure that you guys subscribe wherever you get your podcasts so you can be up to date and be in the know. Just a little plug between you and I, because we didn't really get to do this last month. I'd love to hear from you personally. I would love to have your questions. I'd love to have your thoughts, your ideas. I would love that. You can find me on Twitter. My handle is @Bordeaux87. So it's my last name, Board, with an O, 87. That was my nickname in college. I was Bordeaux and I've never outgrown it. And then the 87, you just need to know I'm from Denver, Colorado, and my favorite Denver Bronco player is Ed McCaffrey. And so the 87 is very, it's ingrained in my soul, the 87. So feel free to make fun of me, but I didn't change it to be professional. It's just @Bordeaux87. But you can also email me at mailbag@bloodstreammedia.com. So either of those, Twitter or the email thing, if you're not up to the Twitter thing, all good, all good. And one more housekeeping item, before we get into the nitty-gritty of the insurance stuff, I want to give a special thanks to Bayer Pharmaceuticals for sponsoring Ask the Expert. Without Bayer's support, conversations like the one I'm going to have today wouldn't happen. So we are so grateful for their support for this particular conversation. Let's do it. We're going to talk about insurance today, and we're just going to barrel through because that's what we have to do. Today we're talking about Copay Accumulator Adjustment Programs. It's a mouthful. I don't know if you have heard about this. They've been around for several years, but they're slowly starting to accelerate in terms of their use. And they're particularly scary for bleeding disorder patients. We're going to break it down for you today because this stuff can be really confusing, and your knowledge of the possibility that this could happen is just going to help you in the future. So we want you to know that you're not alone in this. We want you to know who to contact when it happens, and we also are going to give you some tips today of what to specifically say when you're advocating for yourself to your insurance carrier. I think that's one of the most important things you will get out of today's conversation. So I hope you guys, can settle into it. Maybe have a pen and piece of paper, like you're at school. That sounds brutal. I don't know. Just think, though, that you can always come back and listen to this if you find yourself in this situation, like around May or April, you can always come back to this conversation. That's a cool thing about podcasts, and you can kind of see. So we're gonna have a great conversation today. It's going to be complex. I want to stress the fact that this is complex. But even experts in this stuff struggle with how to navigate their own plans. I mean, this stuff is just ridiculous. So take a breath and know that we're all in this together. The crucial nature of this is why I wanted to have a conversation with our expert today. Kollet Koulianos is the Senior Payer Relations Director at the National Hemophilia Foundation, and she's taken the lead on this issue on a national level. She's assisted many families, and I have to stress, she has really helped so many people as they've been hit with this issue. She's also advocated for this issue for our community, I should say at the state level. She just recently was in Virginia in support of a bill that will address this. So we're very excited to have Kollet here today. We also are going to speak with Lauren Kilgore. Lauren is a member of our community, and she's experienced this Copay Accumulator issue firsthand. And so we get to hear her story and her thoughts on what this looks like and what to do if this happens to you. So grab a cup of coffee and let's have ourselves a conversation. I am your host, Amy Board, and welcome to episode 24, or our Copay Accumulator Adjustment Programs, the insurance nightmare you need to know about episode of the Ask the Expert podcast. We're joined today by Kollet Koulianos, Senior Director of Payer Relations for the National Hemophilia Foundation. Good morning, Kollet.
Good morning, Amy. How are you?
I am so good. I'm so glad that you're joining us. Just to start, just for people to get kind of the full depth of where you have come from, I think you have such a fantastic and fascinating background. You were the executive director of the Bleeding and Clotting Disorder Institute in Peoria, Illinois for years before coming to NHF. What did your role look like at the Institute?
I was the executive director, so I ran the program, the Hemophilia Treatment Center, and started the in-house specialty pharmacy program and all the various aspects that go along with running an HTC.
Was that your first role in the bleeding disorder community, or were you involved in the community before that?
Well, I actually worked at Illinois Cancer Care before that, and the physicians there, primarily the 17 physicians that were there during my tenure, most were oncologists and hematologists. So they did some bleeding disorder activity, but primarily focused only on cancerous or non-benign, if you will, bleeding disorders. And anything that was benign, and certainly any patients with hemophilia, or most of the VWD patients were actually referred to the Bleeding Clotting Disorder Institute and Dr. Tarantino.
I think it's so fascinating that you're not a physician, you're not clinically involved with bleeding disorders, you have an MBA, and you're so involved in this community. I just think it's such a wonderful gift for all of us. You now have a senior payer relations role at NHF, and what in the world does payer relations mean?
My role at NHF really revolves around any payer education, as far as, working together with payers to look at opportunities to drive savings, to help. At the end of the day, let me start over again.
And wait, let's clarify. Payers, you mean insurance payers, insurance carriers that pay for healthcare services, right?
Yeah. So to clarify, any payer is anybody who's responsible for paying the claim. So most people think of a payer as the health plan, right? The Blue Cross Blue Shields or United Healthcare, Aetna, et cetera. But the fact of the matter is there's more payers that are self-funded employers, and they only use the health plans, like I mentioned, United Healthcare, Blue Cross Blue Shield, Aetna, et cetera. They use them as a third-party administrator. So they use their network to administer the claims, but the employer is actually footing the bill. So whoever's responsible in paying the bill and trying to mitigate their risk for these high-cost patient populations would be considered a payer. And so my role here was created when I came on board, because at NHF, prior to my joining, Michelle Rice started what's known as CCSC, which stands for Comprehensive Care Sustainability Collaborative. And Michelle put together 5 hemophilia treatment centers across the country, hemophilia treatment centers, and she brought 5 payers to the table. And there were some national large payers, there was a regional payer, and then there was a payer consultant that was part of the original advisory board. So I was lucky enough to participate from the onset of that program that Michelle started. And frankly, Michelle saw the need because one of NHF's, kind of founding goals, we call them our global ends, what our board expects of us, what we expect of ourselves, is that we want to make sure patients have access to care. And because of the times that we live in, because of the continuing escalation of healthcare costs and the landscape that we live in, there's these threats to that. And one being, of course, the threat to hemophilia treatment centers being able to sustain themselves, because they're largely dependent on their in-house specialty pharmacy for the sale of the clotting factor to help with their program expenses. And more self-funded health plans would carve out their pharmacy benefits to just one exclusive provider, generally their own. They own their own specialty pharmacies as well, and so they would get exclusivity, and then the patients couldn't use the hemophilia treatment center. And so that really puts that model at risk. And NHF helped to start the hemophilia treatment center network back in the 70s, and they know that it's the gold standard in caring for patients with hemophilia. It's the original medical home model. So she started the Comprehensive Care Sustainability saying, yes, we're an advocacy organization, but our goal is making sure patients have access to care and access to the right care. So she brought parties to the table to sit down and try to facilitate dialogue, value-based dialogue between the parties, and say, what can we do to help, bridge any gaps of communication? How do we show the value of the HTC? What is it we need to do? And then for HTCs, what do they need to provide payers to show that value as well? And so I participated from the first meeting and stayed involved in it. And in fact, I am overseeing the CCSC initiative now. Ultimately, I work under Michelle Rice, and so she ultimately sees all of the external activity we do. But this is one of my kind of wheelhouses here. And I work with payers. I think it's our fiduciary responsibility to help bring solutions to the table for payers, where we can show them how they can drive savings, because we want our patients to continue to have access to care.
Is this type of conversation, this high-level conversation with payers, happening in any other disease state, any other disease disorder?
No. In fact, we know from all the largest national payers that say to us continually, we wish other advocacy organizations do what you guys did. And we have been working with other advocacy organizations that are interested and say, NHF is a leader in this area, and we'd love to try to emulate what you're doing, because they see where the value has been added. And as a result, payers come to us when they're trying to make formulary decisions, when they're trying to, manage the high cost of hemophilia, and they're going to implement various utilization management strategies. They come to us to have dialogue with us. They take our input if we think that some of their strategies aren't going to be in the best interest of the patient, or could have unintended consequences and raise prices. And so it has proved very valuable. And, and they're shocked that we feel some responsibility here, but they love it. And they want us to help educate other organizations to do the same.
Obviously, today we want to talk and we want to discuss this very specific insurance issue. This issue is called the Copay Accumulator Adjustment Program, and I think it's incredible that you guys have these relationships at such a high level with these insurance payers. I think we can kind of circle back at the end to discuss how that method has actually helped with some of these very specific issues. But to get into the meat of what we wanted to talk about today, rather, this issue, it all, it's so complex and confusing. Copay Accumulator Adjustment Program. It starts obviously with copay cards or coupons. For those that are listening that don't understand what copay cards are, if you wouldn't mind giving just a short explanation of what they are and why they came into existence.
So yeah, they go by various names. They're basically Copay Accumulator Adjustment Programs. Now, we know that they have some very clever, catchy names. Various PBMs and health plans have come up with some names that are very actually confusing. But essentially, what started the copay coupons from manufacturers? You know, we say, what came first, the chicken or the egg? Well, in our country, healthcare costs continue to escalate at an alarming speed. You know, we have the highest healthcare cost per capita of any other country in the world, and payers are always looking for ways to mitigate their risk when it comes to their healthcare spend. So one of the strategies that's been deployed for several years is rolling out high deductible health plans. And high deductible health plans are basically a shift of some of the responsibility. So if we shift more responsibility onto the patient, then in theory, we make them a better healthcare consumer, and they're going to make better decisions because they're going to have more responsibility to pay the costs than a standard, let's say, PPO plan would. And what that really means is that whatever the deductible is, because every plan has a different flavor and color, but there's whatever the deductible is, which the minimum to be a high deductible health plan and qualify for the health savings account, it has to be a $1,350 deductible or higher. So
for a family or for an individual?
For an individual, but that's a minimum. It can go, we've seen many patients that have $5,000, $6,000. And now, I mean, it can go all the way up to the maximum out of pocket that's set by ACA, which in 2019 is $6,800 for an individual, or $6,900 for an individual, $15,800 for a family. So how a high deductible health plan works is that a member has to pay the entire deductible before the plan pays one penny, right? And so as a response to this growing trend of rolling out more and more high deductible health plans, manufacturers started offering copay assistance cards for these high-cost specialty drugs to help members to be able to access their medication. Because frankly, if your deductible is $5,000, and many families, as you know, in hemophilia, there's more than one member in their family that has hemophilia, they would have to pay that twice up to their max out of pocket. And they don't have that money. So manufacturers started issuing these copay cards to help patients meet these high deductibles. And for a long time, it was a stopgap solution. It did help these vulnerable patients be able to access their medication. Starting in December of 2016, we were alerted to a member who worked for a self-funded employer group who reached out to his hemophilia treatment center social worker, who then reached out to us to say, I think something's changing with my plan and I'm not going to be able to use this copay assistance anymore. So I got in touch with the patient, and then we were able to look at the language of the plan. And I said, well, actually, it shows you can use the card. They just are no longer going to allow that assistance to count to your responsibility, because that deductible and that out-of-pocket is your responsibility. So essentially, if we just say, make it for an easy explanation, if the member has a $5,000 deductible, and just to make this an easy transition, their copay card has a $15,000 annual cap on it by a manufacturer. The member in January could use that copay card to pay their $5,000 deductible. They get their medicine. In February, they use it again because there's still $10,000 left on it in February. And now they have $5,000 left. So March, they use that last $5,000. But none of that counted to the member's deductible or out of pocket. So come April, when the member goes to get his prescription, the pharmacy counter can't use that card anymore. It's exhausted for the year. And the member's left to pay the $5,000 before they can access their medication. And that's where the problem lies for our community, because this is life and death if a member doesn't have their medication. So our fear from the beginning of reading this language was that the unintended consequences were going to result in a very dire situation, potentially for patients, but was also going to result in a higher cost for the health plans, because a member left without the ability to have his clotting factor at home has no other option but to start going to the emergency room and the hospital to get their clotting factor infusions, which is going to be far more costly to the health plan.
In your experience, when this happens, what are patients typically doing when they call their specialty pharmacy and all of a sudden they realize they have to pay this $5,000, $6,000 deductible? Are they going to the ER? Are they panicking? Are they paying it? Are they trying to get it installments? Are they calling you? What are they doing?
Well, the truth is that there are a lot of patients out there that are left and have been left with no other option but to go to the ER. We've had patients across the country who some have been very severe and scary. One being, I know the gal that you're going to speak with regarding her husband, but we had a family down in one of the southern states that had two children. One was having a throat bleed. They were 18 days without their medication, and his airway was restricted. They lived 2.5 hours from the nearest hospital that had clotting factor. So this could have been life and death. And that's what keeps me up at night and why I won't stop fighting until there's some provisions to protect patients who have, chronic diseases like hemophilia that depend on, life-saving treatments and they're being held hostage basically at the pharmacy counter, unable to access these critical treatments.
So what is the reasoning behind this? I mean, surely insurance companies must have a reason to do this because it seems like they're just double dipping. It seems like they're receiving twice the consumer payments.
Well, it's a good point, and I think that's the most important thing you can do, and I'm glad you asked the question. Why is it happening? Because most people don't stop to put themselves in the shoes of everyone around the table. You have to understand that everybody who has to mitigate the risk of this high cost spend is trying to find some way to not only save to reverse this trend of increases every year, but to also start to save money. And so they put these things like the high deductible health plans in place. They know that caused healthcare spending to go down. I mean, the data shows it, that when plans roll somebody from a traditional PPO or an EPO plan onto a high deductible health plan, their actual annual spending goes down because now the member has to meet that entire deductible before they get any healthcare services. So members are far more, if they have to have something done, they're calling around and they're getting, finding the best price. If there's a generic alternative that's a lot cheaper, they're going to go that route. That's great. What they found, though, on the flip side for these high deductible health plans is that a large amount of these chronic disease patients who represent the highest cost spend, who have no generic alternatives, like hemophilia members, who have no other options available to them, were actually becoming more costly. Their total cost of care went up because now if they weren't adherent to their treatments, then they had other unintended consequences. As I mentioned, going to the hospital or ER, having some sort of bleed that's unresolved, which can turn into a target joint and cause other issues. And so, listen, at the end of the day, there's plenty of data. There's over 68 abstracts out there that talk about where the tipping point for these high deductible health plans went. Well, so you asked me, why are they doing this with these accumulator adjustment programs? It's just another utilization management strategy trying to drive patient behavior. If we don't allow patients to count this help towards their personal out-of-pocket responsibility, we're forcing that patient to be a better healthcare consumer. Again, taking back to that, they're going to check around and get the best price. They're going to make better decisions. But there are no, listen, all clotting factor products have coupons available, number one. And there are no generic alternatives, not in the U.S. or any other country. There are no biosimilar equivalents. So regardless, the member is, they're left with no other options. And that's what we're trying to do is show them the data that's already there from shifting patient costs in these vulnerable populations and what the unintended consequences actually resulted in. If you look at high cost claimants as a whole, that defined is somebody who costs an insurance plan $50,000 or more a year. And so in private insurance, commercial insurance plans, the actual average of these folks who are high cost claimants actually average around $122,382 annually. We know hemophilia is significantly higher even than that on average. But if you look at just the national average, that's 29.3 times higher than just everybody else in the plan. And that only represents 1.2% of the population. If I am the health plan, 1.2% of my population of the people I cover for commercial insurance, represents 31% of their spend. So only 1.2% of the people I cover actually attribute to 31% of my spend. So that's their focus. So these these Copay Accumulator Adjustment Programs is just another step in trying to put some more responsibility on the patient and make them savvier, better healthcare consumers, use good judgment, don't get unnecessary treatments. Because if they use a copay card in January and it meets their annual spend, then they think they're going to just willy-nilly go out and do whatever they want without any consideration for the cost to the payer.
To put it in layman's terms, an insurer, a payer, is trying to change patient health consumers' behavior with drugs that have like a generic equivalent. So instead of getting a brand name for Lipitor per se, that, so many people, in the States are on that drug, instead of spending more for the brand name to try to push them to get the generic. And what's happened, the balloon, which is causing massive stress and obviously, damage for our patients, is that we don't have a generic equivalent. And so we're trying to find a loophole for them to deal with these very specific disease states that don't have a generic equivalent. Is that correct?
Right. So we're looking at twofold. Yeah. One being, so you hit it right on the head, and that's exactly what's happening. They're trying to find a way to drive consumer behaviors. And I use this example, and you use Lipitor, so it's a good example because I always say Crestor. When 2 years ago or more, a little slightly over that, I was trying to get my Crestor refilled, and I'm at the pharmacy counter, and the pharmacist says name brand or generic. I said name brand, and he said, just to let you know, your plan year just changed, and this is a tier 4 drug. So it's going to be $180. And I said, oh, how much is generic? He said $5. I said, oh, I'll take the generic. Within not even 20 seconds, he says, oh, actually, I have a coupon here I can use, and it'll be the same price, $5 for a name brand. I go, oh, well, then I'll take the name brand. So I'm sitting there, it doesn't matter what pharmacy it was, but I'm sitting there waiting for the fill because it can happen at any one of them. And as I'm sitting there, I'm feeling guilty because I'm thinking this through logically, going, the person paying the bill on the back end is going to be paying a significant higher price tag because at the time of purchase, this coupon level set the playing field for me. So I had no more responsibility and I could get what I wanted, right? But I'm not giving any thought to the payer. And so I went back up to the counter and I said, if I want to switch back to generic, and they said, well, it'll be another 25, 30 minutes. I said, well, I'm going to do it this time. So I'm not doing that again. And I never did. And this is exactly what they are trying to stop, is that kind of behavior. At NHF, our position is, if there's a generic, we agree it's not fair that these coupons could drive patient decisions like that, and that patients should care about what the payer has to pay, not only because they want to continue to have access to care, but we want to make sure generations to come have access to care. And so it's the right thing to do. And it's same with services. My brother needed an MRI and he had to pay his deductible. So I called around, first time in my life ever called around to check what tests cost. And the delta between, I would call 3, the highest price, the middle price, the lowest price. From the lowest to the middle was a $1,500 difference, and over $1,000 difference between the middle to the highest. So almost $2,500 from the lowest to the highest. And my brother had to pay that deductible. So I can guarantee you he was using the lowest cost option. Had he not had to pay that deductible, would I have even called, or would he call to look for the best price? That's what insurers are trying to stop. And that's what we as Americans, anybody who's blessed with healthcare coverage, should care about. But that's not what For our population and other rare diseases, and there's a difference between high-cost drugs and high-value drugs, meaning life or death, and maybe other drugs that aren't life and death, where if you want to do this sort of thing and there's a generic, we get it. We get why you wouldn't allow them to count because you want the patients to use the lower-cost drug. Or if it's a low value, meaning this isn't a life and death situation. Okay. But that's not what we're talking about. And so for our patient population, it isn't going to save the payer any money. In fact, it's going to be more costly. And it's a life and death risk to our population.
What grouping of plans is this program starting to pop up in? Is it Medicaid? Is it ACA marketplace plans? What are the types of plans that are starting to utilize this Copay Accumulator Adjustment Program?
Well, actually, so it's not Medicaid or Medicare. However, they're trying to use the Medicare example because in Medicare, when a member has Part D, they have what's called the true out-of-pocket protection. So they're in the donut hole, if you will. Let's just say they have to spend $5,000 out of pocket. They do not allow manufacturer copay cards to count towards the member's out-of-pocket for Medicare. However, there is a provision that allows those same Medicare members, if they get the assistance from a third-party nonprofit, like PSI, for example, or PAN Foundation, if they get that assistance from a third-party nonprofit that isn't one specific manufacturer or another, and they do needs-based testing to make sure the member actually is needs-based, and they help the member with that out-of-pocket, it does count to the member's out-of-pocket. So they were kind of copying Medicare. Medicaid, this is not on Medicaid patients. They can't use these assistance cards on Medicaid, but members don't have any responsibility there anyway. Where we saw them first, and primarily the largest adopters still to this day are self-funded health plans. So I told you that, of all the commercial insurance plans, because you've got Medicare, Medicaid, commercial insurance, you have TRICARE, and you have individual. So some people go on the individual marketplace and get their own plan. So it's not an employer sponsored, meaning the employer doesn't help pay any of the premium. It's not offered through your work. Of all the employer sponsored plans, it's right around 50% in our country. So it's the biggest amount of our population are employer, meaning the employer offers health insurance and they help pay the premium. Of that close to 50%, 63% of those are self-funded employers, meaning the employer just uses these payers, these health plans, as a TPA, but they're responsible for the cost of this patient. They're paying the claims. And those are the biggest adopters, where the self-funded health plans are the ones who started to roll this out in mass back in 2017. And then we started to see them on the ACA plans, small quantities of ACA plans in 2017, 2018, larger quantities, more commercial plans started adopting. And this year, the wheels are off the bus. I mean, it's just being rolled out in large numbers.
Have you checked out Living with Hemophilia yet? If you have, kudos to you. Not only are you eager to join the exciting community of discourse and helpful information, you're also a keen listener and patron of the arts. But if you haven't taken a swim through livingwithhemophilia.com, take a moment to pull it up on the ol' internet. I think you'll love it. Helpful content, relevant updates, and, most of all, a bunch of people going through the same things you are. It's a growing part of the online Living with Hemophilia community, brought together by the good people at Bayer. Also, put it on your Facebook to-do list. Hit the like button on the Living with Hemophilia Facebook page. It's a good alternative to looking at the slideshow of your neighbor's recent foot surgery. I mean, unless you're into that sort of thing. Living with Hemophilia from Bayer. Check it out.
What is the outlook for 2019? Is it going to be the same amount of plans, or does it look like more plans will adopt this in 2019?
I definitely think more plans are looking to adopt this in 2019, unfortunately. So we have a lot of work to do. Again, looking at the payer mix of the U.S., it focused a lot of my attention on the self-funded employers. So I have really targeted myself and our team here at NHF targeting the self-funded employer groups and their coalitions, the organizations that represent self-funded employers from a national level and then from a state and regional level, and providing education to those folks. I've been on several national webinars, pushing information out to these employers about the unintended consequences to patients like hemophilia patients. And will continue to spend a large part of my time doing that. And then I also help patients as well. Like when somebody comes to us saying help, I'm like a bulldog. I don't stop until I try to find some resolution. And that's just who I am. And we have a team of people just like that here. So it makes me love my job.
I want to paint a picture for what this would look like if this happened to one of our listeners, one of our patients, one of our families in the hemophilia community. It seems like a perfect time to bring Lauren into the conversation. Lauren Kilgore is a community member who has experienced this issue firsthand. She's brave enough to share her story with us. So Lauren, welcome. Tell me a bit about yourself and your connection to the bleeding disorder community.
My husband, he is a hemophiliac, and we met quite a few years ago, and I really did not have any idea about anything with the bleeding disorder community until, unfortunately, it was a problem, and we were newlyweds, and it was just a big mess. So that's kind of my experience with the bleeding disorder community. I was just kind of thrown into it, and all at once, and it's been a beautiful thing since then, a frustrating thing since then, and a very teachable experience since then.
A part of the frustrating experience, today we're talking about this Copay Accumulator insurance issue, and I know you've had experience with it firsthand. When did this issue come up for you guys?
So it started 2017. We got married in 15, and he never really had a bleeding issue. Obviously he's had it all of his life, but it was kind of like an on-demand type deal. Where, he didn't have it at home. If he had a bleed, we'd go to the emergency room. And then after we got married, I don't know if he just became more clumsy or what, but it's just like it all broke loose. And it was like a year after we had gotten married, and the bleeding started. And 2017, we got him on some insurance, and we were hoping to get Factor at home. We had moved, and we were with a new hematologist, and they had recommended, this amount of dose and this how many times a week and everything. So we got with insurance provider, and we were like, okay, well, let's, get this started. Whenever we got all set up and we were calling the pharmacy to go ahead and get the medication sent, they were like, well, you can't until you pay this. And it was almost $7,000. It was $6,500. So they were just like, this is what you're going to have to pay. This is your deductible. It has to be met because this is a high dollar medication. And we were just like, $6,500. So, how are we going to get that? We're newlyweds. We just graduated college, and we didn't have that money at all. And we had, especially since we just moved, and who has $6,500 for a deductible up at front, especially in the first of the year? So I had called everywhere because I really didn't know what to do. And at that particular time that we were trying to get it filled, it was like a few days afterwards that he had started bleeding in his knee really bad. I'm not really sure of the injury, but I just know it was really bad. Like he couldn't walk, and he was in so much pain. And I really didn't know what to do because, we're newlyweds, and I really didn't know anything about hemophilia. I just knew he was hurting. So I called anywhere and everywhere. If you had a number and it was anything tied to hemophilia, I was calling it. I called at the state level, and I didn't have any answers. They're like, well, we really don't know what to tell you. It's a deductible. It's just kind of what you have to do. And then I reached out to National Hemophilia Foundation, which is like the broadest number to call. I was like, okay, this is just out there. It's the National Hemophilia Foundation. And it was after hours, I remember. And I just remember leaving a voicemail, a very detailed voicemail, and I was crying my eyes out. I was like, these people are going to think I'm crazy. And it was definitely after 5 o'clock, and crying my eyes out. And I was just like, can someone please help me? I don't know what to do. This is my situation. My husband's bleeding. And it was not even but 2 hours after that Kollet called me. And she was just like, hey, I got your voicemail. It was really weird because it was very late in the afternoon. And she was like, hey, I want to help. Tell me a little bit more about it. Told her a little bit more about her situation. And she said, I'll call you 8 a.m. in the morning. So after that, we had so many phone calls, emails, phone calls, anything you can think of. We were just back and forth all the time. And she was just like, this isn't right. And this doesn't sound right. And, she told me that, he should have his factor at home, that he shouldn't be having an active bleed. And this is the issue because of the accumulator adjuster that apparently they had put on insurance with the start of 2017, or the spring of 2017.
So Lauren, just to clarify, before this happened, the $6,500 in the summer of 2017, you thought you had already met your deductible by using a copay card at the beginning of the year for some of the factor that he needed. Was that correct?
Yeah. The prescription he was on, factors Advait, they allow a copay card of the medication. That's what we thought was going to take care of it. Well, after I had talked to Kollet, she was like, this is what they should do, and have you exhausted this option yet? So I did find out about that that way, and they were like, well, you can call them. So I called the pharmacy, not the pharmacy, but the pharmaceutical company that makes the factor, and they said, yeah, well, this is how much we'll allow. And then I called the pharmacy, and I was just like, hey, this is going to be easy. They're going to help us. And supposedly it had happened before, like the copay coupons would take care of the deductible so that patients could get their medication at home. This time it didn't work.
Oh, okay. So this time it didn't work. And this was preventing him from getting his medication. He literally could not get that clotting factor.
Right. And 3 weeks to a month had went by.
So he's still bleeding and he could not get his clotting factor.
Yeah. Yeah.
Oh my goodness.
I talked to the pharmacy, and the pharmacy said, unfortunately, we don't take the copay coupons anymore. It's just, this is the new law. And
hang on. I just want to remind you, they said they would take them, but they didn't count. And since you had used them out that year, you had to pay the full $6,500 out of your own pocket. So that's where the accumulator adjuster. Yeah. Sorry. Just want to make sure you clarify.
Absolutely. Yeah. No, it's so confusing. Absolutely.
They told us that, that the deductible had to be met before anything was sent out. Like they had the whole order just sitting there. And so I was like, what do you want us to do? Like, are we the only people in the world that have this kind of issue? And the person at the pharmacy was like, well, unfortunately, no. This is a new thing, and it's impacted so many people, so many of our clients. And she said that people were taking out credit cards, and she mentioned that one man had taken or borrowed money from family and then took out 5 credit cards, and he was steadily paying them off. And I told her, I was like, well, the difference is that we have no credit. We're fresh out of school. We have loans of our own, and we can't even get a credit card for $6,500. We can't even get several credit cards for $6,500, all added up together. She said, well, you should borrow money. Well, that's okay. If you have people you can borrow money from. She was like, well, do you have any family? And she was literally just naming off family members. She was like, well, what about this person? I was like, what? So we hit a wall. We didn't know what to do, and, they didn't have any resolve for us. So, like I said, he went, weeks with this specific joint bleed that had resolved itself eventually. And obviously with damage, it resolved itself. But we finally got the resolve. Kollet helped us. Talking about, it took weeks. Kollet helped us realize that, he has a Native American status, and we had no idea that could be applied and that would be taken care of just from his Native American status on that standpoint. So we finally got the factor after weeks and after the bleed had resolved itself, and unfortunately, there was damage from that, and that damage from that knee bleed, when we were not allowed to have the factor at home, it's become a target joint. So he has lasting damage in that specific knee that he had that from. Also, with the knee bleed, around that time, after the knee bleed had resolved itself, he had went to the hospital for rectal bleeding. Something really simple as, like a hemorrhoid or something, had become like a life-altering situation. And he had been bleeding for a while, and he didn't realize it until he passed out at work. And he passed out at work, and they transferred him to the hospital, and he was there for almost 2 weeks, a little over a week. And they had to have surgery, and it was all caused from not having the proper factor at home to treat the bleed whenever we found out that it was actually happening. And he could have, he could have died from that. Just he lost so much blood, and they were like, you've been bleeding for a really long time. And anyway, it was a really scary experience for us.
Oh, absolutely. What did you guys do to proactively look at your insurance plan for this year or for 2018? Or how did, if Kollet did Kollet look at your insurance plan to advocate to people to have this not happen? What did you guys do in 2018 to make sure that this didn't happen again?
Oh gosh. Well, between 17 and 18, there was so much that I had to learn about insurance and the type of medication he was on, and what tier that needed to be. And Kollet helped us, pick out a proper, or, she helped us with, go through the benefits of the health insurance plan that we had. So everything that happened in 17, when we essentially got it all set up with the Native American status and everything, it kind of rolled over into the next year. And fortunately, that was our case. Now, not everybody has the Native American status. So
let me explain that here. So in the process of trying to get to somebody that was going to understand the unintended consequences that were going to happen, right? Because now as he visits a hospital, he gets admitted, he has surgery, he has permanent damage, the costs are far greater to the plan than just simply allowing him to have gotten his factor, right? And we're trying to go through that process. And during that, we, looking at her plan language, identified that they had specific provisions, which is a CMS guidance, that if they had Native American roots, they were exempted from these out-of-pocket expenses anyway. So this should never have even been an issue, but I can't even tell. Lauren, I don't know if I'm right. 10 or more calls to the insurance company, and everybody said a different story. And I'm like,
for more.
Yeah, it was a ton. And we sat on the phone over and over, and one person would agree, one person would disagree. And I had to finally keep climbing the chain at Blue Cross Blue Shield because it was in the plan language. And we finally got them to say, actually, you're right. They shouldn't have even gone through this. So they had a workaround that should have been applied. But the point is, this is exactly what happened because of a Copay Accumulator Adjustment Program, right? So, and for them, by just staying on the same plan that they were on, which was my recommendation, I wouldn't rock the boat here. Now we've got it figured out. They wouldn't have to worry about this then in the coming years. Not the case with a lot of patients. And this just goes to show exactly what our fears were from day one when we heard about these programs and what they continue to be.
Right. Well, Lauren, thank you so much for sharing your story. I know it's going to help so many people who have to deal with this issue unexpectedly. And so I just thank you for your time and your candor. And I wish you guys the best. My goodness.
Well, thank you so much. And it's looking a lot better for us now that we know that this issue is still ongoing, unfortunately. And more people than we would like to talk about are experiencing the same exact thing with the accumulator adjuster issue.
Absolutely. Thank you again.
Thank you.
Kollet, listening to Lauren's story, is terrifying. And she spoke a lot of the provisions that were specifically written into her plans for Native Americans. But if folks are not covered by that provision, what can they do if this happens to them? Where should they go? What should the steps be to get this resolved for our families?
Thank you, Amy. Yes, she did bring up the Native American thing, and she was, and her husband, very fortunate to have Native American ancestry, and so therefore their plan did have a provision where they could use the assistance as part of that provision. And so this should never have happened to them, which is on top of it a bigger tragedy, because, her husband has, going to have lifelong issues from these bleeds that went on far too long, and now has a target joint as a result, been in and out of the hospital a couple of times, had surgery, and, it's just really a devastating scenario. Most people don't have that provision. There are many of the health plans and employer groups have communicated, including United Healthcare has gone out publicly and said that if a member is in this scenario and is truly a needs-based patient, in other words, they meet whatever the criteria is for these third-party nonprofit programs, like I mentioned, that PSI is an example, or PAN Foundation, or the Assistance Fund down in Florida, which are the three funds that have some sort of hemophilia assistance programs. If they go through the criteria, if they meet the criteria that the program has in place, which is 400 to 500% of the federal poverty level or below, then they can get that assistance, and these health plans will count that to a member's out of pocket. Because what they say to us is, we haven't thought about the unintended consequences. And we do get that there are a lot of folks out there that just cannot financially afford these kind of high out-of-pocket costs. Because remember, Amy, a premium that a member pays to get their insurance doesn't count towards your annual out-of-pocket. So you have a monthly premium you're paying, any individual is paying, and then you have life costs, right? Your house, your car, your gas, your food, your kids, schooling, clothes, everything that goes with life. And now on top of that, you have these high out-of-pocket responsibilities, as I mentioned, up to $7,900 for an individual, $15,800 for a family. And the average median household income is only $61,000 in our country. So it doesn't compute, and so if you look at it from that vantage point, the payers are trying to be fair. When they hear these scenarios, they're like, listen, if they go through this organization that's going to check their needs, and it's not just going to be a manufacturer handing a card out to anybody, regardless of their means, and it's not just for one product over another, then we're okay with that, and we'll count it. So that's something what we've been happy to be able to talk to our community members about, and has been helpful for many patients. For those patients who don't meet the criteria, but still simply do not have that kind of money around, of course, that's a whole nother issue. And so, and those have, just require a lot of educating for the health plan or the payer. And we have been successful in several cases where they've decided to just take the accumulator adjuster off until they can do some further digging to compare the costs of total cost of care implications if a member is going to start going to the hospital, for example, for their infusion. So we have had some success, but the real challenge is making sure that the most vulnerable patients are not going to be affected by this language.
To kind of piggyback on that, I think, utilizing your voice and advocating for you and your family to, especially pharmacy, to the insurance carrier is so important. And some tools that I heard you say, which I just think are so important to always remember. I would think decision makers at a high level, when they're looking at healthcare, would assume that a normal average human in America would not utilize their out-of-pocket max every year. If something happened one year, if you had like knee replacement surgery or something, like you would utilize that, you would pay into that. Hemophilia patients will pay into that 100% every single year. Their drugs are so expensive. And so to ask a family to pay, $7,000, $13,000 every year for their life-saving medication. And I think this has always been a real key for me when I have sat in rooms with decision makers, that this is not a symptom, erasing drug. This is truly life or death. This is replacement therapy. If they do not get this drug, they have the potential to bleed out and perhaps, die. And so to utilize that, and then to also, I think the other component of this for patients when you're advocating to your insurance carriers is that unintended consequences. Going to the ER, what would that cost? I'm going to have to go to the ER to infuse my child, to get my child the medication 3 times a week, or twice a month. Add up the cost of what that would be. Those are really good points that I hope listeners at home are kind of making notes if this happens. These are the points that you can use when you're advocating for yourself to your insurance carrier.
Don't go to especially self-funded employers, and say, if you do this, I'm going to, not only be in a lot more pain, but I'm not going to be able to work. I hate to sound like this, but sadly, and again, if you put yourself in their shoes and you go to them and say, but by implementing a program like this, I could have to quit. Sadly, I'd like to say that there's an awful lot of employers that would be happy to hear that, especially if they're trying to manage their costs, right? And I'm not trying to be, negative Nelly. It's just a fact. The truth is, for our population, is that they're doing this as a cost-saving strategy. This is going to backfire on you. And that's how they have to kind of approach this as a patient trying to talk to their health plan, is that you will leave me with no option but to visit the ER. And it could be as many as, 3 times a week or more. And the site of care for an infusion in the hospital is significantly higher than letting me just get my factor at home. And, the other thing is medical and scientific guidelines, recommend patients have access to not only their PRN or their prophy doses, but have extra doses at home in case of an emergency. They're putting their life at risk, right? Little kid, Johnny, hits his head on a table running and playing with his brother. He needs to have clotting factor infused within an hour. That in almost no scenario can I think of where from moment of injury to being in a hospital and being, admitted into the ER and infused within an hour, is that going to happen, right? And so they need to let their employer know what these kind of consequences could mean, and that they're going to have to go to the ER. That's the only option they're leaving them. That's the kind of picture they need to paint.
It's so important. And most of this is education. No one has any idea how to treat hemophilia. I mean, 9 times out of 10, you go to the ER and, the physicians that are supposed to know, they don't know. Another reason to, build those self-advocating skills for you and your family. Kollet, do you think HTCs and chapters across the country are educated on this issue? Are those 2 safe places that patients can go to have questions answered?
I definitely think they should start there with their chapter, with their HTC. An awful lot of HTCs have been hungry to get information and, have reached out to us. Can you provide us with resources we can share? What should we have a member do? So that's certainly a great place to start. Same with the chapters, of course. And that's, they're driven by making sure that patients can advocate for themselves and have all the resources and tools they need. But there's always going to be outliers and challenges that require further assistance. Most often, though, those chapters or the HTCs will reach out to us, and we'll get engaged and try to help. So,
what are the efforts that NHF is doing to address this issue? And are there any efforts going on at a federal level or at a state level that would address this issue specifically for these high-cost patients?
So NHF has been engaged from day one, right, Amy? Like, we're the first to kind of identify the issue and take it out and educate other folks in the community.
I mean, I remember when you started talking about it, I mean, it was like this vortex weird thing. And now when I Google it, there are pages and pages and pages of articles about it. I mean, you guys really were on the forefront of addressing this.
Right, because at the time that I identified it and I tried to find information, because I was trying to even get folks in our, on our team and our pharmaceutical part, folks that have drugs specifically for hemophilia, or I couldn't find anybody who had ever even heard of it, let alone believed that it was real. They kept thinking that can't be, that's double dipping, that's illegal. Well, the fact of the matter is, it's more than double dipping. Like if the card was $15,000 and the deductible is $5,000, they're collecting that 3 times from the card and once from the patient, if the patient could actually afford it. So that's 4 times. So that's quadruple dipping as an antidote there. But I couldn't find any. There was not one thing on the web. And today, you're right. You could just keep page after page after page on the web and find information, and that's just in 2 years. From when this was first identified. But since then, we've worked closely with educating other advocacy organizations, educating the pharmaceutical companies, whether they're hemophilia pharmaceutical or not, working with a couple of advocacy organizations, Arthritis Foundation and AIDS Institute, Anna Hyde and Carl Schmidt, respectively, and NORD, National Organization of Rare Diseases, and MS. We started a steering committee to form an accumulator adjustment coalition. And so from a federal level, we're working hard to try to get the message out to our respective communities through both traditional platforms, through whatever resources each organization has at their disposal, but also through social media. We've done a video to try to help explain it, which can be found on NHF's website, or you can go to YouTube and search National Hemophilia Foundation and look up Accumulator Adjuster, and you'll see the video. I think it's pretty explanatory.
And it will also be, just a note, it will also be in the program notes of this podcast, that video. It's a phenomenal resource. So you will have a link right on your program notes when you download this podcast.
Perfect. Thank you for that. And so, yeah, and then from a state level, our state team, Nathan, Brendan, and Bill, they do an amazing job of getting information out to the states and to the chapters. And so, they're working, many states are trying to put language into some sort of legislation, some trying to get accumulator adjuster language added, like making that like some sort of legislation. And then other states like Virginia trying to prevent accumulator adjustments, which I was there testifying for both Rhode Island and Virginia last week. And, we're in a good place. The bill passed both the Senate and the House, has to do the crossover bills. And so hopefully we'll get traction there, and that will become law where they will not allow accumulator adjuster plans in Virginia. So fingers crossed. And then there are several other states, right? West Virginia, Kentucky is looking at language. West Virginia has a proposed bill, Indiana, Arizona, Connecticut. And so we're not only keeping tabs on those, but we're going to be, I'm heading out to Indiana, Kentucky, and West Virginia, in fact, in the next 2 weeks to do some training there with other advocacy groups, and then to speak to legislators and do some media interviews to talk about, what the challenges are with these programs. And I can honestly say to payers when I go to them, I can look them right in the eye and say, listen, we've come to you with solutions to help you drive savings. And in many cases, tens of thousands, hundreds of thousands of dollars in savings, sometimes even for one patient. And so we're trying to be good stewards of your healthcare dollar. We're telling you this is not a good strategy. It is going to end up being something you regret down the road. And we're just trying to prevent that from happening to save everyone pain. Right. So that's at the end of the day. And we have had a meeting with CSIO, who, the head of CSIO's policy for ACA plans. So we're going to continue to work on that level. And our folks, Nathan and Marla, who are working with our NHF Washington Days, are putting some points together that we'll share with the folks that come in here in March to do our Washington Days, which is always one of the largest advocacy days on the Hill. And, we won't stop until we solve all of these kind of healthcare dilemmas. So I guess it's job security in a way. But I think we have some of the best folks out there fighting for our community.
Oh my gosh. Yeah, I can second that. You guys do tremendous work. And a plug to the folks that are listening. If you have experienced this issue, or if you do this year, I think I just want to hopefully encourage you to reach out to your local chapter, regardless if they help or not, but reach out to your local chapter and tell your story. When this stuff comes up, especially in those states that Kollet mentioned that are, there's some rumblings that they're starting to get language together to address this. But even if you live in a state that was not on that list, decision makers really value your story, and we can't make our point without your story. I know Kollet is the expert going into the rooms a lot of times, and she is so compelling, but what would be even more compelling is if they had, a patient story right next to her that said, this is how this affected me and my family. So please reach out to your chapters. They will know exactly what to do. It's very, very, very important.
I would also, just let me add one thing, huge agreement by me, everything you just said. And if any members listening have not only had the accumulator adjuster issue, pop up on their plan and have had to suffer any of the unintended consequences, meaning they had to go to the ER for treatment or hospitalized, getting a hold of those explanation of benefits, your EOB that you get from your insurance, so that we can show the differential and what this would have costed versus just letting them dispense at the pharmacy, point of sale, is really, really the best weapons we can use to try to get the message out there. We have to show how this is going to hit the pocketbook.
Absolutely. And, hemophilia families and patients, hemo moms, man, we are such an educated community when it comes to dealing with insurance companies. So, brush up on those skills, document everything, and reach out to your chapters. Kollet, to close, I kind of wanted to have a brief conversation a little bit just about the psychosocial effects that some of these insurance issues can have. I just kind of want to touch a little bit on the anxiety and the fear that, this conversation is going to provoke in patients. We haven't had, an insurance issue like this for a few years. And it's just so scary. It's so unbelievably scary. And so I just wanted to see if you had any words of comfort that you could to provide to our listeners as they kind of navigate this issue, as well as so many other insurance issues that we're all going to be dealing with in 2019.
Right. So my advice in that scenario is, I know it's scary. I know these things are going to raise concerns, but the hemophilia population has at their disposal a whole lot of champions out there that are working hard on their behalf, whether it's obviously, as I mentioned more than once, that our whole team at NHF is pretty darn amazing, starting with Val Bias, our CEO, and down. But our entire community, there's HFA, there's the chapters, right? There's chapters in every state. There's feet out on the street all working on behalf of this community, and together we're going to make a difference. We won't allow this to happen without at least raising our voice loud and clear, and we will try to find solutions to help in the interim. And so I feel like for not having that many people with hemophilia in our country, right, 20,000 or so, we have an awfully loud voice nationally, and our patient population should have some sense of security that there's a lot of people out there. It's certainly not just me. We have a whole team of folks in this country working on behalf of these patients.
Thank you again. This information was invaluable, and hopefully it can be used for the good here in 2019 and beyond. And a special thank you to Lauren for sharing her story. It's so brave for her to come forward and offer what her experience was like with this. Thank you to the both of you, and we will see you soon. Thank you so much.
Yeah, you bet. Thanks, Amy. Bye-bye.
Listeners, be sure to check out the program notes to find links to the video Kollet mentioned that details this issue. You'll also find other resources in our program notes as you continue to educate yourself on this issue. Follow NHF on Facebook and at their website, hemophilia.org. And that is all for episode 24 of the Ask the Expert podcast series. We will be back next month with another expert interview.
Have you checked out Living with Hemophilia yet? If you have, kudos to you. Not only are you eager to join the exciting community of discourse and helpful information, you're also a keen listener and patron of the arts. But if you haven't taken a swim through livingwithhemophilia.com, take a moment to pull it up on the ol' internet. I think you'll love it. helpful content, relevant updates, and, most of all, a bunch of people going through the same things you are. It's a growing part of the online Living with Hemophilia community, brought together by the good people at Bayer. Also, put it on your Facebook to-do list. Hit the like button on the Living with Hemophilia Facebook page. It's a good alternative to looking at the slideshow of your neighbor's recent foot surgery. I mean, unless you're into that sort of thing. Living with Hemophilia from Bayer. Check it out.
BloodstreamMedia.com is your one-stop shop for all of Bloodstream Media's podcasts for the bleeding disorder community.
Once on BloodstreamMedia.com, don't forget to follow the links to subscribe to the Bloodstream Podcast, Ask the Expert Podcast, the Powering Through Podcast, and the Bloodline Podcast on iTunes, SoundCloud, or wherever you listen to podcasts.
Have an idea for a future episode of Ask the Expert? Have a question that you would like to hear an expert answer?
Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on facebook.com/bloodstreammedia and on Twitter at bloodstreaminfo.
This episode of Ask the Expert was written by Amy Board.
Produced by Patrick James Lynch.
Rob Bradford.
Joshua Sterling Bragg.
Avra Friedman.
And Colby Crow. Artwork by Katie Wright-Mead.
And Ryan Geelan.
And the Ask the Expert podcast is edited by Allison Stoney.
I'm your host, Amy Board, and until next time, embrace that mystery and fear of life. You are not alone.